Welcome to this evening's webinar, When the Stomach Won't Cooperate, Advanced Strategies for Gastroparesis. My name is Angela Buffington Johnson, and I will be your host and moderator this evening. As we get started, and by way of virtual introduction, I have two questions to get us to let us help us get to know our audience a little bit better. So go ahead and grab your phone and open the camera, and you can go ahead and scan that QR code and answer the question. Which is, what is your primary role in treating patients? So are you a GI? Are you a surgeon? Support staff? We'll just give it a few moments here. The polling should advance, the polling should advance on its own as you scan the QR code. There we go. Oh, perfect. And for those of you on the app, you can go ahead and if you're doing the watching this from your phone, you can click over to a browser window and type in slido.com and then put in that 5113730, and that'll show as well. So it looks like we have a variety so far of different roles within the different medical practices that are represented. All right. And now if you keep your browser open, we'll move on. And then if you could rate your experience level with treating patients with gastroparesis. So this is maybe you don't see a lot of patients with gastroparesis, or you do, and you love seeing them. So it's kind of what's your experience level?
Angela, I think next time we are missing the vomiting emoji.
We can add that in. That would be appropriate. All right. Well, we have, again, I'm excited for this webinar, and it's nice to get to see the different types of attendees and levels of experience that we have here tonight. All right. So one other thing I will mention on the housekeeping front is to please utilize the chat feature throughout the webinar, and that way you can submit your questions, and we'll make time at the end to get to those questions. All right. It is my pleasure to introduce today's speakers. Dr. Alsheik is the director of the Center for Motility Disorders at Henry Ford and serves as medical director of the Henry Ford Specialty Care Centers. She specializes in diagnosing and managing complex gastrointestinal, esophageal, and motility disorders, including gastroparesis and achalasia. She believes in treating the whole person and not just the symptoms, and has a long-standing passion for expanding access to high-quality care. Dr. Sujka is an associate professor of GI surgery at the University of South Florida and the co-director and founder of the USF Neurogastromotility Center. He specializes in gastroparesis and minimally invasive surgery. He is also deeply engaged in teaching and has published more than 60 papers and is active in multiple surgical and gastrointestinal societies. Dr. Sujka is committed to ensuring patients feel heard and supported, and he strives to provide the best care possible. So please join me in welcoming both Dr. Alsheik and Dr. Sujka. Oh, and Dr. Alsheik, I'm not sure if we can hear you.
Oh no. Do you want me to advance past the slide and jump right in?
Oh, yes, I'm sorry.
Oh, okay. Sorry. You guys should have never trusted me with advancing the slides. I'm clearly not to be trusted. Hi, everybody, and welcome. I'm Eva Alsheik. It's really nice to spend this beautiful summer Tuesday night with you all. So hopefully we can hang tight for the next hour and learn something new. So the objectives of tonight's webinar, we're going to talk about gastroparesis as a neuromuscular disease of the stomach. We're also going to talk about how these patients might present, how to diagnose them, and we're going to go through the current treatment algorithm. We're also going to talk about why gastroparesis belongs in a busy GI or surgical practice, and then where electrical stimulation fits into that as an advanced treatment, especially after diet, lifestyle modifications, and pharmacologic therapies for gastroparesis have failed. All right, and I have started every gastroparesis talk since 2011 with this slide. So some of you might have already seen this slide, but I trained in Philadelphia, and Philadelphia is separated from Jersey by the Delaware River. And across the Delaware River is Camden, New Jersey. And there's not a whole lot to see in Camden, New Jersey. You kind of just drive through Camden to get to the shore or other parts of Jersey. And so one of my mentors used to always say, gastroparesis, it's like Camden, New Jersey. Everyone knows it's there, but no one wants to visit. So with that, I hope you will join me for this tour of Camden over the next 45 minutes or so. All right, so gastroparesis. With gastroparesis, there is a very large unmet patient need. What we know is that there are about 700,000 patients diagnosed with gastroparesis in the United States. Gastroparesis accounts for about 2.5 million Google searches per year, and there are about 100,000 plus members across gastroparesis support groups on Facebook, Instagram, and other social media outlets. So these patients are gathering and they are learning more information through these support groups and learning about where to find specialists when it comes to this chronic disease. So that being said, there's a significant clinical and program opportunity to kind of build up a program to care for these patients. So we know the demand already exists. These patients are searching for experienced providers, and these centers can really offer advanced therapies and become regional referral hubs and trusted destinations for complex GI patients. With gastroparesis, really, you can be as busy as you choose to be and create a program that works for you within the confines of your institution. So we all know that gastroparesis is a challenging chronic gastrointestinal disorder. It's characterized by impaired gastric emptying in the absence of a mechanical obstruction. Key symptoms of gastroparesis might include nausea, vomiting, bloating, early satiety, and abdominal pain. But we all know that if this disease process is not managed well, these patients end up being high utilizers. They end up blowing up your my chart. They require frequent return visits. They end up showing up in our ERs. They have a high readmission rate. So our goal in the therapy is really to get them as functional as possible and as early as possible within their kind of journey of their condition. So the way that we understand gastroparesis and its patients has fundamentally evolved. So what we do know, again, like I said, is that about 64% of gastroparesis patients have visited the ER within a year of diagnosis, averaging about 3.6 visits per patient over the course of a year. The average length of stay for patients in the year before they've gotten a neurostimulator device was 13 days. So again, very taxing not only on the patient and their ability to kind of function and lead a normal quality of life, but also on healthcare institutions as well. 27% of hospitalized patients had unplanned readmissions within 30 days, with 46%, so nearly half of patients being readmitted within 90 days. So again, the disease burden is high, both personally and across the healthcare continuum. All right. So what we do know is that gastroparesis is a heterogeneous disease, and again, it's defined by delayed gastric emptying. And we have some major underlying causes of gastroparesis. We tend to put diabetes in one of the majority of buckets. We have iatrogenic, which could be our post-surgical patients. And then we have idiopathic, which is where we kind of put our post-viral, maybe some of our autoimmune, maybe some of our neurologic or infiltrative disease type patients. The pathophysiology of gastroparesis, we know much more now than we did a decade ago. We know that it could involve impaired relaxation of the fundus, gastric dysrhythmias, hypomotility, pyloric spasms, and we'll talk about that in subsequent slides. The cardinal symptoms that a patient could present with are also very, very heterogeneous. So some patients might present more on the nausea vomiting spectrum, while others might be the early satiety, bloating, fullness, and then the dreaded pain symptoms. So before we get into kind of the dysfunctions of gastroparesis, it's really imperative to understand how a normal stomach works. So when we eat, UES opens, we have peristalsis in a top-down fashion of our esophagus. our lower esophageal sphincter relaxes, and eventually that food bolus ends up in the fundus of our stomach. The fundus then accommodates or relaxes to kind of accommodate that incoming food bolus. And then the process starts. So then you start getting mixing of the stomach both in a circular and in a longitudinal fashion. And that food bolus is broken down into smaller particles that eventually are propelled forward into the antrum. And then the pylorus serves as almost a sieve or a filter. So when those particles are sufficiently broken down to a small enough size, they pass through the pylorus and into the small intestine where they're absorbed through the small intestine wall. And then we have to also talk about the fact that there is a pacemaker region of our stomach, with interstitial cells of Gahal being kind of the main drivers of the rhythmic activity of our stomach. So usually our stomach moves in kind of a 3 cycle per minute way. If there is bradycardia of the stomach or bradyrhythmia of the stomach, meaning too slow of contractions, or tachyrhythmia of the stomach, meaning too fast of contractions, you can develop disordered movement of the stomach, and that can translate into symptoms. But really, there can be a dysfunction at any level of the stomach that could lead to this disease process. And what we found is that depending on where the dysfunction is, could correlate with the symptoms that patients have. So in a patient with impaired fundic relaxation, for example, these are the patients that might report early satiety. So doc, I have a half a cup of liquid and I just feel so full, I feel so bloated, I just can't finish anything else. In patients who have gastric dysrhythmias, those patients might present more with nausea. Those with a dilated or hypomodal gastric antrum, those are the ones who have who feel full for longer amounts of time. Patients with pylorospasm also might feel fullness, discomfort, bloating. And then, of course, we have any number of dysfunctions in the stomach that could cause the dreaded pain. What we also know is that it's not always clear whether a patient has gastroparesis or functional dyspepsia. And sometimes a patient can oftentimes toggle between both of those disease conditions. So gastroparesis, as we know, is impaired gastric emptying, kind of defined as a delay in emptying at 4 hours on gastric emptying scan, or greater than 10% retention at that 4-hour mark. Functional dyspepsia is defined as all of the common symptoms of gastroparesis in the absence of a positive gastric emptying scan. And so in this particular study, what they found was when patients were tested at baseline and then again at 48 weeks, 42% of patients with the initial diagnosis of gastroparesis normalized their gastric emptying scan and were reclassified as functional dyspepsia. In 37% of patients who had normal gastric emptying scans, when they were retested at 48 weeks, they toggled over to abnormal gastric emptying scans and were reclassified as having gastroparesis. So this would kind of suggest that this is not a static process, but instead a dynamic process, and that patients can kind of move in and out of this gastroparesis diagnosis. And there might be other pathophysiologic abnormalities or mechanisms that ultimately drive symptoms. So nausea and vomiting in gastroparesis is not only a function of stomach dysfunction. We say that it's a neuromuscular dysfunction, meaning that there are multiple sensory inputs. There are gastric mechanoreceptors that feed to our central nervous system that can perceive nausea, and at a certain threshold of nausea, vomiting can occur. Vomiting, on the other hand, is more of a motor reflex. So we get contraction of the diaphragm and the abdominal muscles. We get an increase in intra-abdominal pressure. We get retrograde contraction of the gastric antrum and proximal duodenum. We get relaxation of that LES, the UES, and then boom, you vomit. But then we also have to think about that all nausea and vomiting doesn't always have a gastric origin or a CNS origin. The differential for diagnosis for nausea is actually very, very broad. So one of the first things that I do in a patient who presents to my clinic with nausea is I'll go through all of their medications. And while we know that kind of there are common offenders like opiates and GLP-1s, which are like nearly ubiquitous at this point, it seems like everybody is on them. Medications that are very, very common, that are more kind of bread and butter medications, can also cause nausea. So our antiarrhythmics, are antihypertensive. Antibiotics are a big one. Our chemo and radiation therapy, all of those can cause kind of nausea type symptoms. Anticonvulsants, diuretics. So always important to make sure that there's no offending medication and try to figure out the temporal correlation between the onset of symptoms and when and how long that patient has been on the medication. There are also psychogenic reasons for nausea. There are endocrine and metabolic reasons for nausea as well, adrenal insufficiency, DKA, hyperglycemia in general. So anytime that blood sugar goes north of 175, it can make us nauseous. Parathyroid disorders, of course, pregnancy, uremia, anything neurologic, and then other gastrointestinal etiologies that could contribute to nausea. So SIBO, dyspepsia, a viral gastroenteritis, obstruction, post-infectious IBS can sometimes present with kind of nausea, feeling unwell, feeling bloated, those types of symptoms, pancreatitis. So always kind of important to have a running differential diagnosis in the back of your mind of, is this really gastroparesis or could this be something else? So when it comes to making the diagnosis, of course, you always want to make sure that the symptom profile fits the picture, right? Does the patient kind of have one of the big five: nausea, vomiting, early satiety, fullness, pain? And one of the first things you want to do after taking a thorough history and doing a good physical exam is checking endoscopy, right? You want to make sure that there's nothing obstructing the stomach or the proximal duodenum up until kind of the extent of the scope that could be causing kind of an outlet obstruction type picture. So is there a whopping ulcer in the antrum that could be causing such symptoms? You might want to consider, depending on the patient's symptomatology, cross-sectional imaging or an upper GI series perhaps. But really the gold standard of how to diagnose gastroparesis is a 4-hour solid phase gastric emptying test. This is our scrambled egg beater with toast and jam test. I always tell patients it's not a painful test. It's just very long and annoying. So bring something to read or bring an iPad. And then every hour on the hour, they'll get their belly scanned. And if there's more than 10% retention at that 4-hour mark, it is diagnostic of gastroparesis. Of course, when you get this done, you always want to make sure that the patient is not on anything that could prolong their motility, so that they're not a chronic cannabis user, or they're not actively taking their opiates, or of course that they're not on a GLP-1 agonist. So again, I kind of put the time frame of when you should hold these medications in advance of getting a gastric emptying scan. And this can be really tough for patients, especially the DLA THCs, especially in Michigan. But the GLP-1 agonist, it says greater than 4 weeks, but now we have so many GLP-1 agonists on the market that it really kind of depends on what the half-life of the medication is. So just kind of make sure to hone in on what the patient is on and kind of figure out when you have to hold it. And so the reason why this is important is because if you have a positive gastric emptying scan with a firm diagnosis of gastroparesis, it does open the door for treatments beyond kind of diet, lifestyle, and medical/pharmacologic therapy. So there are patients who simply can't tolerate the gastric emptying scan. I mean, we see this all the time. So what options do those patients have? These are slightly more kind of niche procedures. They might not be available at all of your centers, but certainly they are available at kind of more TQ type centers. So there's the spirulina breath test. There's gastric allimetry, which is body surface mapping of the stomach. There is an endo flip to measure the distensibility or the stiffness of the pylorus if you're suspecting kind of a more pylorus stenotic variant. And then there's antroduodenal manometry testing. So kind of important to kind of know where these different tests are offered if you don't have them within your center. So you can come to a firm diagnosis to better treat your patients. So when it comes to managing gastroparesis, we have firm guidelines, right? We have guidelines that came out in 2022 by our national societies, and then they were updated again last year. And we all kind of agree that the cornerstone of gastroparesis therapy is really to optimize nutrition. So diet and lifestyle modifications are very key. So educating a patient on small, frequent meals throughout the day, making sure they're sticking to low fat, low fiber, easy to digest foods. If they are in bad shape and you deem them to be malnourished, don't shy away from enteral nutrition if that's what the patient needs to kind of build up their stores again. Of course, we want to make sure that the patient's A1C is zipped up and that their glycemic control is kind of well looked after. Also, because it doesn't matter what you give to a patient, if their A1C is 14, they're never going to feel great, right? So after you've kind of managed and educated a patient about diet and lifestyle modifications, the importance of glycemic control, making sure they're not on any offending meds, then we kind of move more into our medication bucket. So with medications, I generally tend to think of medications in two kind of major spheres. I think of our antiemetics and I think of our prokinetics, and we'll do a deeper dive into both those categories in subsequent slides. Of course, pain is always a really tough one because you never want to give these patients opiates if you can avoid them. Typically, we'll more so revert to our neuromodulating medications. So our SSRIs, kind of our mirtazapines, our TCAs, those types of medications to help pain in those patients. When a patient then fails those, that's when we move into advanced therapies, and we'll talk about that more in the second half of our talk. So when it comes to how to kind of counsel a patient about diet changes, it can be really tough, especially in our diabetic patient population, because our diabetic educators are telling our patients eat fruits, vegetables, whole grains, foods with kind of a low glycemic index. Well, on the gastroparesis side of things, we're saying carbs are your best friend. They will be digested and tolerated easier, right? So what we found is that registered dietitians actually improve outcomes. And the way that our dietitians at Henry Ford approach things is that you want to do as much of the digesting outside of the body as possible. So it's not that you can't ever have, a green bean again. It just has to be fork tender, something that you would give a baby when you feed them. It has to be in small amounts. You have to chew thoroughly. And of course, anything in liquid form is going to be more easily digested than anything solid. So that holds true also with liquid fats. Those are better tolerated than solid fats as well. And again, just those small frequent meals throughout the day are going to be digested more easily than a proper breakfast, lunch, and dinner. The problem in this patient is, especially in the Midwest, is that obesity is rampant. And sometimes, and it's not infrequent, these patients come to our clinics and they are obese. There can be a bias towards these patients. How sick can you possibly be if your BMI is like 35? Like, you must not be that bad, right? But what happens in these patients is, they're sticking to more of a carbohydrate diet. When you don't feel well, the last thing you want to do is be active, run around, engage in those activities that really can drain you, right? And what we know is that about 46% of patients with idiopathic gastroparesis are actually overweight or obese. Their metabolism essentially shuts down, and they just kind of are storing fat, very little muscle. So it's this terrible paradox in these patients. So a few slides ago, we talked about kind of the major buckets of medications that we have, and we have a whole laundry list of antiemetics that you can choose from. Typically, I look at a patient, they've probably already come to me on different medications that they've already tried, but I always want to make sure that they don't have anything glaring in their cardiac history, like a prolonged QTC, that might make me kind of reach for an aprepitant or a scopolamine patch instead of an ondansetron, for example. But this is just kind of skimming the surface of all of the different things, or all of the different types of medications with different mechanisms of action that you can march through depending on how the patient tolerates medications, whether or not they need intranasal, sublingual, transdermal delivery. So there are options when it comes to antiemetics. When it comes to prokinetics, though, we really only have one FDA-approved medication for gastroparesis, and that's our OG metoclopramide. So this medication used to get a really bad rap about some of the kind of neurologic side effects, like tardive dyskinesia, that could come as a result of it. But what we once thought as kind of a very kind of concerning side effect is actually much rarer than we once understood. But it is still something to keep in mind, and certainly if a patient has any history of those types of movement disorders, that would not be something that I would recommend. We also have domperidone, which we know is not clinically available stateside. A patient would have to get that from Canada. Again, you'd have to very closely monitor their EKG. You have to apply for an IND through the FDA for this medication, so it can be a bit cumbersome to get this medication for your patients. We also have erythromycin, which is commonly an antibiotic, but it also works on the motilin receptors of our gut. It can be titrated up. You can give it before meals as well. And so this can be a good option for some patients. And then the newest kid on the block is prucalopride, which is FDA approved for chronic idiopathic constipation, but it also has the secondary benefit of accelerating gastric emptying. So this has been a really nice prokinetic to reach for in patients who have concomitant gastroparesis and also chronic constipation. So now we're going to do another live poll. So if you can pull up your Slidos again, the next question is what makes you decide it's time to escalate? So again, you can scan the QR code, you can join slido.com. So at what point do you all pull the trigger and say, I think this patient needs a little something more? We'll just give it a couple seconds. No improvement, status quo. Absolutely. All right, we'll just get a couple more because it looks like a couple more people are typing. Hospitalizations is a big one. Excellent. Non-responder to medical management. Absolutely. Wants to be off meds. Yes, that's big these days, right? Refractory to lifestyle and at least one med, failed meds, extreme symptoms. All of these are wonderful answers, and you're absolutely right. So now we're going to talk about what is a refractory patient? When do you escalate care? And there are a couple of different triggers for escalation. So persistent symptoms is definitely one of them. You guys mentioned that. And that's despite diet, lifestyle modifications, antiemetics, prokinetics. Maybe you tried some neuromodulators. Maybe you even tried fluids, enteral feeding. Patients still not getting better. You might want to consider more advanced therapies. Patients who have required frequent emergency department or inpatient hospital visits, and those who are just crippled by the impact that this disease has had on their quality of life. So when we say, how do we kind of define refractory to drugs and diet? How that's defined is poor or no response to medications in two different categories. So a prokinetic and antiemetic or an anti-nausea with diet and lifestyle modifications. So, symptom-based approach to gastroparesis, we always want to make sure that we're not only kind of treating the test or the number or the percent retained on a gastric emptying scan. We really want to treat the whole patient and all of their symptoms, right? So when we diagnose gastroparesis, we definitely want to avoid overdiagnosis. We always want to consider a possible overlap with functional dyspepsia. Sometimes the diagnosis is not always clear. Sometimes we have like 11% retention on gastric emptying. Those can be really tricky patients to deal with. We also want to assess their predominant symptom and severity, right? So are they more on the nausea vomiting spectrum or are they more on the bloating, fullness, early satiety spectrum? And then when do we consider either endoscopic or surgical therapies? That's when they have moderate to severe symptoms that are really refractory to medical therapies. And with that, I will pass it over to my colleague, Joe.
Good evening, everybody. Just to remind you, my name is Joseph Sujka. I'm down at the University of South Florida. I'm going to be taking over for talking about our surgical approaches to gastroparesis. And there's a lot more out there for surgical management of gastroparesis than there once was. Entera has been around for quite some time, but one of the new kids on the block is GPOM and pyloroplasty becoming a bit more common in the last 10 years. And then there are your things like bariatric surgery, like sleeve gastrectomy and total gastrectomy. On this slide, you can kind of see from left to right, kind of least to most invasive procedures. And this is to sort of suggest that there are different procedures that have different risk profiles. And we'll talk about that as we're going through these, slides. But also, there's a certain amount of reversibility with some, but not all of these procedures. So right now, we're going to start with Entera therapy and then move on to pyloric interventions after that. Give it a second. It'll go, I promise. And if not, I might have my handy dandy online people try and click me through here. There we go. So the first we're going to touch on is gastric electrical stimulation, or Entera. This targets patients who have chronic drug refractory gastroparesis, and it's very good at controlling things like nausea and vomiting. And really, the benefit of the device is that it's adjustable and reversible. Unlike a lot of the interventions you're going to deal with, there isn't really something here that can't be taken out or reversed. And so as a result, for patients, it can be very attractive because they're not changing their anatomy. They're just adding something to it. And then not only that, unlike a lot of other surgical procedures, you could adjust the device as patient symptoms change over time. And I think something to underscore is that these patient symptoms will change over time. They're not going to be static forever. And so one of the benefits of GES, gastroelectrical stimulation for short here, is that it is adjustable. So the indications for it are those who have nausea and vomiting, who are refractory to drugs and diet, and fall into diabetic or idiopathic gastroparesis patients. They also have to be an appropriate surgical candidate. You want to consider before taking these folks to the operating room optimization and making sure that they don't have cannabis hyperemesis, they're on narcotics, or they have other things that should kind of keep you out of the belly, like peritonitis or ascites. Also, something you need to talk with patients, especially for those patients who have fibromyalgia, scleroderma, that MRIs can only be done of the head and extremities. So for people who have chronic back pain, need MRIs more routinely, maybe you think about talking with them about it before you put in the device. Also, if people need shortwave diathermy, which is pretty uncommon nowadays, it's another reason to sort of avoid putting in the device. So how gastric stimulation works is also multifactorial. Just like there's multiple problems throughout the stomach, there's also multiple things that the device makes better. There are studies to suggest that it improves fundic relaxation, making early satiety better. It improves that dysrhythmia or the abnormal rhythms of the stomach, which helps with nausea and vomiting. And it improves the amplitude of the signals that are going through the stomach, helping with that fullness in the hypomotility of the antrum. And then we also think that there's a little bit of a gut-brain connection here as well, where vagal signaling from the brain is improved and decreases symptoms as well. There's definitely an element here of the vagus nerve and the myenteric plexuses that sort of lead to issues. But a lot of these things work in concert to help these patients. And so when you talk about gastric electrical stimulation, it starts from the bottom of this slide up. The symptoms are targeted through multiple pathways, starting at the stomach, improving gastric accommodation, and then 3 cycles per minute of rhythm and amplitude, which comes up to the vagus nervous pathways, increasing your parasympathetic activity. There's also some studies that show that there is an anticholinergic or anti-inflammatory pathway here. And then it reaches up to the central nervous system through cortical regions involved in the visceral sensation. So these are those feelings of fullness and pain sometimes that patients get. And then as those things coalesce together, you have nausea, and the patients feel better from their nausea because of all of these different actions. And how do you measure these improvements over time? The Gastroparesis Cardinal Symptom Index Scale, which I will now say GCSI from here on out, is a scale that's utilized for quantifying nausea and vomiting. I was really pleased to see that a lot of folks here have managed some of these folks before based on your emoji responses anyways. And one of the things that you know is that these patients' symptoms change over time. They change day to day. And the GCSI is useful for asking the patient, how do you feel today? Because when you ask them that question, they want to tell you about a lot of different things that are going on in their lives, medications, stressors, surgeries they had, doctor's visits they had. But the GCSI allows you to quantify the nausea, the vomiting, the fullness and early satiety, and the bloating and distension. And speaking to starting a program, it's imperative that you decide how are you going to monitor these patients. Are you going to use GCSI or a different similar scale to show the patients over time that they're changing, they're getting better? Because sometimes it's very difficult to show people how they change over time, especially with folks like this who have a lifelong problem that needs chronic management. So GCSI is something that I would encourage you to get familiar with or decide what you're going to measure on patients. So some of the data around Entera is going to be presented here, and we're going to start with a study that came out just recently from Wash University. And this showed that there was a decreased hospitalization throughout with patients who have Entera. So there's about a 78% reduction in hospitalization and a 91% reduction in total hospitalization events. This is showing that at about a year, these patients are now less in the hospital. And from my own experience, I see this all the time. There are patients that I see once every couple of weeks, and then when we put in their device, sort of lose them. They come back every so often to check in, but ultimately they get their lives back. They stay out of the hospital. And it's a really strong benefit of this device because they're not having those severe drug refractory symptoms that they were having before. But not only that, this is durable at 5 years. So this is a big table, but I'll draw your attention mostly to the top, where it shows that at 1 and 5 years, this effect is durable. And this is important because other therapies, such as bariatric surgery or GPOM or pyloroplasty, tend to have worsening outcomes as you get farther away from the procedure. And honestly, that's because of homeostasis in the body. The body figures out a way to get around the surgery that we have done. But in this scale, you can see that not only did GCSI in total decrease in a statistically significant fashion, but so did nausea and vomiting. Other things did as well, postprandial fullness and bloating. But ultimately, the focus for this device is that nausea and vomiting subscale. There's also data looking at 10 years of patient data showing that this continues to be durable. The next is looking at the French Ministry of Health study. I'll take a poll of people to see if anybody read this study during 2020. We were all very busy with something else. But unfortunately, this trial came out. It's a randomized controlled trial out of France during the pandemic. So nobody really heard about it, unfortunately. But they looked at patients who were diabetics and non-diabetics to see whether or not the gastric neurostimulator helped with their vomiting. Now, you might be looking at the screen and going, wait a second, that number went up. But the way that the French did their study, as many ways the things the French do, is that they use their own scale. So on this scale, an increasing number means an improvement in the amount of vomiting that occurred. So looking at this study, when patients had their device on, which is the orange on your slide, in both diabetics and non-diabetics, the amount of vomiting that occurred decreased. So again, a little complicated to explain, but ultimately the trial in a randomized fashion showed that the device was helping with patients vomiting. And one of the things that came out of that study was that they did include some normal emptiers. I did see a message in the chat asking about, well, if the gastric emptying study is inconsistent, how can we trust it? And I think that that's something that people have been asking for a long time. And one of the studies that Entera is currently running is Navigate, which is looking at those patients who have normal emptying, but also chronic nausea and vomiting to see if Entera is an option for those patients. And hopefully within the next year or two, we will have the information to tell you what to do with those patients specifically, because I would agree with the person who put that in the chat that gastric emptying studies are inconsistent and they're difficult to interpret at times because the rate of emptying and the rate of retention don't really bear anything on the patient's symptoms. So I would tell you to look for further on this. There's various sites throughout the country, and I'm proud to say that we are one of them. And there's a QR code on the screen if you have patients who need to be evaluated for this study and you are looking for help for them. So now we'll turn our attention a little bit to the pylorus. Unlike Entera, the pylorus is a procedure where the muscle is cut, meaning that it's irreversible. We only have 7 sphincters in the body, so anytime you cut one, you have to be a little nervous about what the rest of the 6 are going to do. But ultimately, this is a procedure where you cut the muscle and you sort of get what you get. The pyloric options for cutting are GPOM, an endoscopic procedure, or a surgical pyloroplasty, another cutting procedure. There are interim steps you can use, like balloon dilation or Botox, but this is in your decision making what you want to use. Ultimately, if I take people, I do a TTS balloon of 220 and I put that across the pylorus and I stretch it for a minute. Sometimes if that fails, I'll take people for Botox, but Botox was studied in a randomized fashion and was found to be no different than placebo. So it's recommended as a second line therapy, and it's sort of unclear on whom benefits from that. So when you talk about pyloric interventions in a more permanent fashion, GPOM and pyloroplasty are generally what you're going to be talking about and reaching for. But one of the things to talk about is that pyloroplasty or GPOM can be additive to Entera. The GPOM and the pyloroplasty specifically are best for patients who have that fullness and that early satiety. The ability of the stomach to empty is improved by cutting that muscle. But when you combine it with gastric electrical stimulation, ultimately the outcomes that you get are better. Now, that doesn't mean that everybody needs a pyloroplasty or a GPOM at the same time, but it is something that should give you pause to say, maybe I do these things together if the patient had a response to a pyloric dilation. When you look at the actual change over time and what happens, you can see on the far right of your screen that when you combine Entera and pyloric surgery, you do have a statistically significant improvement in nausea and vomiting. Now, if you look at sort of the Entera and pyloric surgery alone, you could wonder whether or not the vast majority of that nausea and vomiting is from Entera alone. But the truth here is that they are additive. And patients who have these two things together can definitely see an improvement in their benefits. I hypothesize that this is because the pyloric intervention is sort of a quick effect. It opens up immediately, and the Entera will take some time to show improvement, but ultimately, together, they can be better. So the practical algorithm for gastroparesis starts at the top of diagnosing the patient appropriately, having things like nausea and vomiting and a delayed 4-hour gastric emptying study. After that, you have to optimize them nutritionally. If they have diabetes, you need to make sure their A1C is well controlled. You also need to make sure that they have lifestyle and medication optimization. Make sure they see their dietitian. If you have a GI psychologist, which is wonderful, have them see them. Make sure that you are doing the appropriate things for them, and then adding in things like medical therapy, like prokinetics and antiemetics, as Dr. Alsheik so eloquently went through. And then at that point, you have a decision to make. Is this patient a nausea and vomiting predominant patient? Do they have those as their symptoms? That might be your best patient for Entera. For those patients who have early satiety, postprandial fullness, maybe you talk with them about their pylorus. But ultimately, you can also discuss with them combination therapy depending on how they respond to EGDs and dilation. But it doesn't end after those procedures. You still have to follow them, titrate their device, titrate their medications, and monitor their symptoms because those settings may go up or down on their Entera. They may need medication support. Some of the things I saw was talking about getting off of medications, and I think that's a truly noble goal. But I will say that that's a conversation to have with patients and set expectations appropriately because there is times where they're going to need medications. There are moments where they might backslide. And ultimately, you need to set those expectations appropriately so they don't feel betrayed if they do have to go back on one of these medications that they're currently on. So these are patients you already see. I'm going to give you a patient profile here to try to chew on. This is a 38-year-old female who has nausea predominant symptoms and has been in the ER twice in the last 90 days. She's got a abnormal gastric emptying study with 28% retained and has failed medical management. Diet modifications haven't worked, and rule outs are all complete. So at the end of the day, with shared decision making, which approach do you think is going to help her more? Is it, gastric electrical stimulation as an adjustable and reversible tool, or a GPOM for satiety and fullness predominant, where you do endoscopic or a surgical myotomy? Ultimately, for this sort of patient, Entera is probably the right answer. One of the things that I really want to get across is that, Entera is here to try and help, right? There is a lot of resources available through Entera that does not just include, reps who can come and help you with the procedure. They've spent time and effort to get patient advocates on the phone who have the device, training people who have educators, flyers and handouts so you don't have to make them yourself, and online resources and webinars like this that are both provider and patient facing to try and help patients and providers find the right answers. Ultimately, if this is a patient population you choose to tackle, which I would applaud you for, make sure you know what your resources are. You're not out there alone. There are plenty of things available that you can get through Entera or through people like us who are doing these sorts of treatments to help you get off the ground and be successful in treating these patients. Talking again about that, there's on-demand education, peer-based learning, as we talked about, and again, these live and these virtual learnings, which you are so graciously giving us your time with. So closing thoughts here is that gastroparesis is a neuromuscular disease with varied symptoms, but a clear treatment pathway. And there's more to therapy than doing diet and medication. Ultimately, there are options, surgical options, as well as medical therapy. But patients need us to step up and help them because ultimately they're having a really rough time. Their life is difficult. Anybody who's had nausea and vomiting for more than 2 hours knows that it makes you want to play in traffic. And every time I think about patients being nauseous for 6 months, a year, just anything that can be done to help them, they need. So they need us to step up and help them. And I didn't mean to steal all of the thunder, but Dr. Alsheik, did you want to close out some thoughts as well?
No, that was a beautiful closer. I can't top that. So I think with that, we can probably move on to the Q&A.
I think so. I'm going to click one slide, make sure I don't completely mess that up. And there we go. I didn't go past it.
We did it.
Yes, well, thank you both, Dr. Alsheik and Dr. Sujka, for the clarity and the education around gastroparesis and of course, that treatment pathway for the patients. We have received several questions in the chat. And just a reminder, everyone who's listening, please feel free to utilize that chat feature, and then I'll voice the questions to Dr. Alsheik and Dr. Sujka. All right, to get us started, I have a question here. What do you now know about treating gastroparesis that you wish you had known when you first started?
Do you want to take that first, Dr.
Yeah,
Alsheik?
I think I can start. I think when I initially started treating gastroparesis, I felt like I had to do everything for the patient from A to Z. And I would say that now I know that it truly takes a village to treat these patients. And when I first started off, I didn't have that village. I had to kind of beg, borrow, and steal resources to get the patients kind of that multidisciplinary care that I think that these patients need and require. So kind of establishing those referral relationships with the registered dietitian. Um, I would use the bariatric dietitian from time to time. Behavioral health. So making sure that that psych component is being looked after as well, because I certainly don't think that you can treat a patient's stomach without treating their kind of overall psyche was really key. Making sure that you kind of elicit the help of your surgical friends if you feel like that's appropriate. So just kind of building a network within your institution of other kind of like-minded experts who feel passionate or compelled to teach to treat these patients, I think has made it much more manageable. Because I feel like we are kind of a village that wraps our arms around these patients as opposed to kind of me being overwhelmed by every element of caring for these patients, which is just simply not doable in the 30 minutes that we have per patient in my practice. So.
And I'd like to echo that. I'm going to take a little bit more of a tactile one to this. Um, I think that it's quite interesting, the practice of medicine and business, right? And one of the things I think is really hard sometimes when you're starting out is to figure out, what am I doing? How do I bill for this? What do I do? How do I make sure that I'm getting reimbursed for doing this and taking that time that you're talking about to raise a village? And one of the things I was really thankful for when, I sort of first met Intero was that they have a group that will step in and help making sure that you're getting all the appropriate codes and billing for this. Because as we've sort of alluded to, these patients can be quite tough. They can be quite challenging and they can be quite time consuming and you can't help them. But ultimately, I think I was sort of surprised and confused about, how do I bill for this? How do I make sure that I'm getting paid to do the job that I need to do? And I know that that's not necessarily the touchy-feely answer, because I agree completely with what Dr. Alsheik said. But ultimately, I think it's a truth about these patients that you don't want to get into a situation where it's hurting your practice because you have these patients who are difficult. And I'm actually sort of find it funny sometimes when, I'm working with trainees and they ask me, well, why do you take care of these patients? And I tell them, well, I really love taking care of them. I love giving them their life back. I love letting them eat where, they really couldn't before. But also, do you know how medicine works with regards to billing? And then I talk to them all about it, and they're like, oh, wow. So again, not the touchiest of feelings of answers, but I do think that when you first take on a new disease process, it's important to know, how do you get paid for it?
That's excellent. I love the dichotomy between your answers. That's great. All right, next one. There are a lot of misconceptions about gastroparesis. What is one misconception you'd like to clarify once and for all?
Oh, I got this one. The gastric emptying study percentage doesn't matter. That's the one that I wish I could scream from the rooftops. Because you'll have people come in and say, this patient is extremely ill. They have 98% retention at 4 hours. And I ask them, and they're like, I vomit every so often. And I just wish I could take the gastric emptying study, wring its neck, and throw it in the trash heap forever. Because it has a lot of problems that I really dislike. And thankfully, we are moving into a time in our lives where I think it will become useless again. So that's just my opinion.
I think that kind of you know limiting our treatment approach to one narrow set of kind of algorithms can be really frustrating for patients. And I always try to kind of impress upon them that there's always kind of something else, right? There's always something else that we could be trying, even if the algorithm says that we've like reached a hard stop. I kind of don't believe in that hard stop. We can layer on medications. We can have you circle back to the dietitian. Maybe we like think a little bit more about your pelvic floor and like your constipation and make sure that's teed up. Maybe we send you to acupuncture or go down the like complementary alternative medicine route. Maybe we try a G poem on top of a neurostimulator that's always there, right? Maybe at the end of the day, like you're somebody who might just be suffering from really bad reflux, so we need to do a bypass, right? So I feel like there's always like I hate when patients come and they say, my referring doctor told me like I'm done. Like there's like no other options for me and this is the last resort. It's like, well, is this the last resort? You still have like 15 different options we can look at, right? So I think that element of instilling hope is okay. Now I feel really touchy-feely, Joe, because
No, we are hope givers for sure. I absolutely agree with that. Absolutely.
but I think that just kind of always, considering what else could I do? Like digging deeper, like listening a little bit more into the history and thinking about like, what could we be hearing this next time we talk to the patient that we could consider. So always just kind of a keeping an open mind.
That makes perfect sense. Not too touchy-feely at all. Okay, Dr. Sujka, you touched on some of the proposed mechanisms by which gastroelectrical stimulation may improve symptoms. Someone has asked if there is data to support that GES can actually improve gastric dysrhythmias.
So that is something that has been hard to measure for a long period of time. Ultimately, most of the studies looking at the change in gastric dysrhythmias were specifically in direct serosal contact studies that were utilizing things like dogs and rat models, and this was 20, 30 years ago. And so they used very low functioning electrogastrographies. There wasn't really a lot in the way of understanding how does that dysrhythmia change. There are new studies utilizing allimetry, which is a body surface gastric mapping device to look at both pre and post patients who have had gastric electrical stimulation. And there is some suggestion in those studies that there is a change. I will tell you that that is an ongoing study at a couple of sites. And so ultimately, that is all pre-published data. But there is some suggestion that that is improved. But most of that is sort of older studies looking at, dog models and things like that in the past.
Makes sense. Thank you. Um, Also for you, Dr. Sujka, is there a subset of patients in whom you would consider fundoplication with pyloroplasty or alternatively gastrectomy of the Roux-en-Y reconstruction?
And that's a complex picture with patients. Ultimately, if patients have a lot of reflux and gastroparesis, I have a risk benefit discussion with them. When you do a pyloroplasty, you have a risk of bile acid reflux, which is somewhere between, 5, 10%, depending on the literature you look at. Some people don't get bothered by that at all, and the reflux doesn't matter. Others do. And so those people who have reflux, I have a very clear-cut conversation with them and discuss with them the reflux. But I insist with those folks that I take them for an EGD and dilation of their pylorus ahead of time to see what happens to their symptoms. If their reflux stays unchanged, if their symptoms improve, then absolutely I'll do a fundoplication and a pyloroplasty at the same time. With regards to Roux-en-Y, that is definitely an interesting conversation because there are patients who walk through the door who say, I want to bypass. It happens not infrequently. They're not interested in sort of other advanced therapies, but most of the time they're looking for help with diabetes or comorbid status that they think would help with a gastric bypass, and they can't get it because of their insurance or some other reason. So I have that conversation with them a lot. When you talk about the outcomes from that, it's pretty good. Patients can have improvement in their comorbid status. But the question always becomes, what do you do with the remnant stomach? Do you take it out? Do you leave it? When I started, I took everybody's remnant stomach out. Since I've softened a bit and I leave it in there, but that does mean at times there needs more interventions later on to decide whether or not that needs to come out for one reason or another.
Thank you. Dr. Alsheik, anything to add or any thoughts on that? I know that's the surgical side.
I mean, I think that Joe pretty much nailed it. Nothing really more to add. That was excellent.
Okay.
It's
All
I
hard to
right.
tried.
follow Joe. It's really hard to follow him.
I do my best impression of a good medical doctor. That's my goal most of the time, is I want somebody to go, are you a gastroenterologist? That's the compliment I'm looking for.
You wear more than one hat, Joe.
Yes, yes.
I do.
Okay, so we have a few questions that have come in around when and how to use gastric electrical stimulation. And then just a quick reminder, Entera therapy is indicated for nausea and vomiting in patients with diabetic or idiopathic gastroparesis. So with that in mind, do you ever consider GES in patients post-fundoplication, particularly in cases with suspected or known vagal nerve transection?
I can tell you my short answer is no. But Joe, I know you've got a little more experience with this.
So what I will say is that the labeling for Entera is such for diabetic and idiopathic. That's pretty much the most I can say. If you want to go look up other studies that have been done, you can. And that's a very specific discussion with patients and what they're having. What I will tell you is that I think that GPOM and pyloroplasty make more sense from a physiologic standpoint in those folks. Because if you have a damage to the vagus nerve, you're having unopposed sympathetic fibers going to the pylorus, meaning it's chronically contracted. So if you cut that muscle open, they should have some improvement in their symptoms. Now, again, there's all kinds of data out there. I would encourage you to go look, but the labeling for Entera is the diabetic and idiopathic patients. But I do think that the physiology makes sense. And generally speaking, I start most of the time with a pyloroplasty or a GPOM on those folks first.
All right. Still kind of along those same lines on the surgery side, do you ever use GES post gastric bypass, and where would the leads be placed?
So this is something that's very interesting because the conversation becomes, well, how does it work? With regards to it, yes, I will put it in patients' remnant stomachs. You have to measure 10 centimeters away from the pylorus. Sometimes you have to deal with the roux limb in the pouch. It can be a little messy. But the main problem with putting in post bypass is that you can't see the leads. So you have to put a port in the remnant stomach to drive an endoscope through to confirm that it's not penetrating. So it becomes a little bit more complicated to do, but it absolutely can be done because generally speaking, the vagal nerve fibers are retained when people do the gastric bypass. When they're on the lesser curve, they tend to separate the nervous and vascular structures from the wall of the stomach and don't transect it. So if you're stimulating the remnant stomach, you're still getting those same vagal afferents from the stomach itself.
Dr. Alsheik, are you more likely to refer your patients for GPOM or pyloroplasty?
It's a great question. And it's actually one that I think between me and Dr. Sujka, we've gotten many, many times. And I think it kind of depends on the culture of your institution, quite honestly. In my institution, our surgeons just don't do pyloroplasties that frequently. So we tend to shift more towards GPOM. We have like a 40 patient backlog right now for GPOM. So we are doing at least like 4 to 6 a week in terms of volume. So I think that's kind of the preferred mechanism in our patients. It's a short procedure. It's less than an hour. It's endoscopic. They are admitted for kind of, maybe a 23-hour observation. Some patients we discharge home after the procedure, after a brief observation period, especially if their upper GI series is negative for any kind of overt leaks or perforation. So I don't know how it is at your institution, Joe. I think it depends if you have also advanced endoscopists who feel comfortable with this procedure. Most importantly, we're very lucky that we do have two of them. So I think it's just kind of cultural and what kind of expertise you have at your center.
Yeah, I do GPOM and pyloroplasty. So to me, it's sort of dealer's choice. I do most of my pyloroplasties at the same time as an Entera instead of just a strict surgical pyloroplasty, mostly because of the reasons that Dr. Alsheik outlined about the ease of doing a GPOM, quick discharge, patients tolerating it well. But ultimately, I don't think that there's much of a difference from a structural change standpoint, but there is some literature to suggest that surgical pyloroplasty has increased improvement in symptoms, but also an increase in side effects. And I think that that simply comes to the size of the myotomy, the disruption of the serosa and the mucosa, and the fact that you're not in the third space. So I will do both of them, but ultimately I usually start with a GPOM, and then if I have to move on to combination therapy, I will do a repeat pyloroplasty to make sure everything's open.
All right. Dr. Sujka, you spoke briefly about the Navigate trial, and I believe
Mhm.
both of you are Navigate sites. Could you please share some additional details on the trial for us?
Sure.
Go
Did you want
ahead.
to go first, Becca? You
Either
want me
way.
No,
to?
no, we're actually not a site. Our
Oh,
site is 4 hours away, but I do refer to that clinical trial. But Joe, you can take it away since you are the PI at your site.
Yeah. So Navigate is looking at patients who have normal emptying but refractory nausea and vomiting. And the idea is to randomize these folks to either on or off with the device itself. So the way the trial is run is patients have to have nausea and vomiting up to a certain level. They have to have a survey about 2 weeks beforehand to make sure that they meet those criteria. They are implanted with the device. The device is left completely off, never turned on, and then at their outpatient follow-up are randomized to on or off and then monitored over several weeks for symptom changes. Ultimately, at the end of that period, they are, unblinded and then given a decision on how to affect their therapy, either turn it on or off. And the reason for that design is because previous studies had the device turned on at the start. And there's a carryover effect with the device of about a month. So if you turn the device on at all, you can have some kind of washout and abnormalities of signals. So that's the way that the trial was designed. And so we're enrolling across the country for those patients who, can't get implants or other procedures because they are normal emptiers.
That's very helpful. Thank you. We have time for just this last question, given that we're at time. But again, I will remind everybody that we are, if you reach out to us through the info@interotherapy.com, we are able to connect you with our faculty and get you connected with therapy consultants in your area. But lastly, are there any newer medications coming out for gastroparesis? I'll direct this one to Dr. Alsheik.
So yes, there are multiple, they're not multiple. There's really not that much. We had Rellamorelin. I think that stopped in the phase 2B trial. We have one that starts with a Y and ends with a bunch of other numbers that I think is in the phase 3. So yes, there are medications in the pipeline. But as history shows, these medications are very slow to release with varied efficacy. So I think we're all still waiting for more medications with bated breath.
Yeah, the nice thing is that phase 3 trial is looking at a medication similar to Raglan that is more specific in its efficacy and action, so it has less side effects. And there was several trials recently of neurokinin 1 antagonists recently that looked at things like aprepitant. The problem is that they really didn't show efficacy unless you look at a dose-dependent response. And ultimately, it's sort of hard to convince and tell people they're going to have to be on this expensive medication and they have to get up to a certain dose and it may or may not work. It is on the list of medications, but ultimately your mileage may vary.
I see. That makes sense. All right. Well, thank you both very much again for your time. We're going to share, just you can continue your educational journey with us. We have a QR code here that will take you to our Educational Resource Center, as well as to finding out if you have a patient that is right for enterotherapy. I'll just, you can go there and find all sorts of information, but we do have monthly webinars for our patients that can come on and learn more if they're a candidate for Entera, but just learn more about gastroparesis. Gastroparesis Awareness Month is coming up in August, so start planning for that. And we do have other webinars and virtual course options available for everyone as well. Again, I always learn so much from Dr. Sujka and Dr. Alsheik. You guys are a great combo. Thank you for spending your time with us this evening. And until next time, thanks, everybody.
Thanks.
Have a good evening, everybody.